The great approach to rating certainty of evidence and moving from evidence to recommendations has become the worldwide standard for looking at whether or not you have trustworthy evidence or the extent to which you have trustworthy evidence and deciding on recommendations that are going to help clinicians and patients. Very wide uptake, over 120 organizations worldwide, including the World Health Organization and the Cochrane collaboration, big American organizations, American Thoracic Society, American College of Physicians, and the leading resource that clinicians go to worldwide to guide their practice up to date, which has over 10,000 graded recommendations. The grade approach has been spectacularly successful, but has got too complicated. Grade leaders have, for a bit, lost the balance between simplicity and methodologic rigor, erring on the side of too much sophistication, and with over 50 grade papers, disorganized. We have addressed this problem for the people who create grade guidance, those who create systematic reviews and practice guidelines. So I'm going to describe the core grade approach, the essentials of grade, which we have just summarized in 7 papers in the British Medical Journal. The core grade approach for any clinical problem starts with defining the patients, the interventions, the comparators, and the outcomes. And what it focuses on is outcomes that are important to patients. We call this the PICO approach: patients, interventions, comparators, and outcomes. Having defined the PICO, one looks for the highest quality or certainty evidence available to address your PICO. And you do what's called a systematic review. What makes a systematic review systematic is, first of all, this careful definition of the PICO, a comprehensive search for the evidence, assessment of the risk of bias in the studies that you find, and then conducting a meta-analysis which gives you the best estimate of effect for each of the patient-important outcomes. So that's what we mean by a systematic review. And then we go to the guideline panel, and the guideline panel has a broad representation with research experts, but also clinical experts who spend their lives taking care of patients. Patient partners participate, and methodologists participate in this. And the guideline panel then considers the evidence and makes their decision. I'll say briefly, when the systematic reviewers apply core grade, what they think about. They think about study design. In the core grade approach, randomized trials start as high certainty or quality of evidence on grades approach to certainty, which has high, moderate, low, and very low certainty of evidence. Non-randomized studies, otherwise called observational studies, things like cohort and case control studies, start as low certainty evidence. But the randomized trials may not end up as high certainty evidence. There may be not too many patients and events. We call that imprecision, and that may lower our certainty of evidence. The results may differ from study to study. In some studies may show a benefit, some studies don't, and if we don't know why, that lowers our certainty of evidence. We have standards for randomized trials. We'd like randomized trials to be blinded. We'd like them not to lose lots of patients to follow up. If they don't blind and lose lots of patients to follow up, we have lower certainty evidence. The studies may not be including the same patients as we're interested in. I practice as a secondary care hospital-based internist. Nowadays, quite a few of my patients are over 90. Can I be confident that the results from the randomized trials apply to those patients? Not so much, because almost no patients over 90 were in the trials. So we have to consider the inconsistency, the indirectness of the evidence as well. Now we've got our summary of we've got our best estimates of effect, we've got our certainty of the evidence, and we produce summary of findings tables, which have nice summaries of all this information, including what we call plain language summaries for the clinicians and for patients if they want to look at the results of our core grade approach. And so I'm going to return now. So you have the guideline panel that I described to you, and the guideline panel now has the responsibility of looking at that evidence and moving to a recommendation. And in the grade approach, they'll make one of two recommendations. They will make a recommendation for the intervention, or they will make a recommendation against the intervention. And then they will decide on the strength of the recommendation. Upsides clearly outweigh the downsides. They're going to make a strong recommendation. A close balance between the upsides and the downsides, or a lot of uncertainty, they're going to make what we call a conditional or weak recommendation, which acknowledges that they may be recommending for or against, but there's going to be some patients who, because of difference in values and preferences, might prefer the not recommended intervention. And that brings us to what the panel is considering when they decide on for or against, and they decide on a strong or weaker conditional recommendation. And they are considering the benefits, harms, and burdens of the intervention in the comparator. They're considering the certainty of the evidence, and they're considering values and preferences. That are the key things from the individual patient perspective. Sometimes within core grade, we also take a secondary population or public health perspective where we consider additional issues, cost, feasibility, acceptability, and equity, ultimately leading to strong or conditional recommendations that recommend for or against the interventions of interest. So that is the summary of the core grade approach for the practitioners, for the systematic reviewers, and the guideline developers, appearing in 7 papers in the British Medical Journal. And so from the point of view of the clinicians and the public, we now have, you can rest easy that people who are using the grade approach now have one-stop shopping to find out the essentials of grade to produce the optimal recommendations that you as patients or clinicians can use to guide your clinical care.